Good morning, everyone. We will give Zoom about a minute or two to add everybody into the room, and then we'll get started. Thanks so much for your patience. Good morning, everyone. We're just giving Zoom another minute or so to let everybody in, and then we'll get started. Thanks so much. Okay, hopefully Zoom has had time to add everyone. We will go ahead and get started. Thank you, everyone, for joining us. I'm Greg Phillips with Duke Communications. Welcome to this latest Duke media briefing on reproductive healthcare. Laws banning abortion have taken effect in multiple states since the US Supreme Court overturned Roe v. Wade last year. North Carolina currently forbids abortions after 20 weeks of pregnancy, and Republicans in the state legislature are debating further restrictions. We have three Duke obstetrician gynecologists with us this morning to discuss the impact abortion restrictions have on reproductive healthcare. With us this morning is Dr. Beverly Gray. She is Division Chief of Women's Community and Population Health at Duke and founder of the Duke Reproductive Health Equity and Advocacy Mobilization Team. Also joining us is Dr. Jonas Swartz. He is Director of Family Planning in the Department of Obstetrics and Gynecology at Duke and a researcher in reproductive health equity issues. And we have Dr. Brenna Hughes, who is Division Chief of Maternal Fetal Medicine at Duke Health. Good morning to you all. Dr. Gray, we'll start with you. Abortion is currently legal in North Carolina, but where do we stand in relation to our neighbors, and what is access like in this state currently?
Thanks, Greg. North Carolina is already a restrictive state when it comes to access to abortion. We have one of the strictest waiting periods in the country with a 72-hour waiting period and state-mandated counseling that we're required to review with patients before they can see us for care. Physicians can only provide care. There's a telehealth ban. There are restrictions around administration of medication abortion, which are not evidence-based. So we're already living under a lot of restrictions. Since the fall of Roe, the 20-week ban went back into place. And while abortion care in the second trimester at or around 20 weeks is very rare, these cases often represent a time when something terrible has gone wrong with the pregnancy, and patients have something going on in their life that impacts their need to seek care and to see us in our clinic. So, like you mentioned, most of the states surrounding North Carolina have strict bans, and while we're still allowing care through 20 weeks, that means patients are sometimes crossing state lines to receive care after their restrictions are set in their state. And what we're worried about right now is that further restrictions may impact care for the women in our state who are seeking evidence-based care. And we know the legislature is currently considering additional bans with a lot of discussion around a 13-week ban or even a 16-week ban or a 6-week ban, excuse me. And we hope to convey why these gestational age bans are dangerous for the women in our state, and they'll impact maternal mortality, which we'll talk about, infant mortality. And this is counter to the will of the people in North Carolina. A recent poll from Meredith College showed that 57% of North Carolinians support preserving abortion rights as they are currently enjoying them or even expanding them, with only 34% of folks wanting a restriction or a ban on abortion care.
Absolutely. Thank you, Dr. Gray. And we're certainly going to dig into a lot of the things that you brought up there. Dr. Swartz, for now, I'd like to move on to you. As we've established, abortion is currently legal in North Carolina only after 20 weeks, but there are a lot of misconceptions about what that means and doesn't mean. Can you review kind of some of the facts about the current law in North Carolina?
Yeah. I think the first thing that we need to remember is that there's a reason that the American Medical Association, that the American College of Obstetricians and Gynecologists, that the World Health Organization all state that abortion is evidence-based healthcare, and access to abortion is really important to help keep our patients healthy. When we care for patients around the 20th week, I want to echo what Dr. Gray said, that as you progress to later to the the mid-trimester of pregnancy, those abortions are rare in our state. And so they represent, at 20 weeks, around less than 1% of the care in our state. However, the patients who are seeking that care oftentimes have gotten some recent bad news. So, a circumstance we commonly care for is people who have gone for their anatomy ultrasound around that 18 to 20 week time period. Now, people often think of that ultrasound as an exciting time when they may get to learn the sex of the baby and see on the big ultrasound screen, but it's actually a really important time where our maternal fetal medicine colleagues take a full inventory and look really carefully at the anatomy of the developing fetus. And it's often at that time that they identify fetal anomalies or changes in the fetal anatomy that may threaten the life of the baby in the future, or may mean that that baby would face significant health consequences, maybe multiple surgeries once it's born. Families at that time period are currently stuck in this really tough decision-making time period where they want to get full counseling, they want to understand what the findings were of the ultrasound, they may need to see multiple medical specialists to understand that, they may need additional genetic testing, and right now, because of the 20-week ban, they are rushed in that process. We actually do the anatomy ultrasound earlier than other states that have access to abortion a few weeks later in pregnancy, precisely because we want people to have more time to make those decisions. But what that means is that oftentimes we cannot see some of the anatomic development. So, views of the developing heart or views of the developing brain, views of the developing spine. And so those women are brought back for another ultrasound later in pregnancy. That can be stressful. It can incur additional cost for the patient. And if you were in a state where you didn't have to delay that, where you didn't have to, hurry up that care because you could get an abortion later if you needed to, you wouldn't have to do that early. We want to be able to provide compassionate and comprehensive care to our patients. We want them to have the time and the space to make the decisions that they need to about their bodies and their pregnancies. The other groups who may need abortion, in that 16th through 20th week of pregnancy are people who have more difficulty accessing abortion care earlier in the pregnancy. So I think of people who are low income. I think of the over 50% of women of reproductive age who live in counties without an abortion clinic in North Carolina. I think of young women or adolescents and teen women who may not realize they're pregnant until later, may need to figure out how they're going to talk to their parents, whether they would like to seek judicial bypass, have more barriers to care. So that 20-week limit already makes the care difficult for the patients that we serve.
Absolutely. Thank you, Dr. Swartz. And similarly, there's a lot more to dig into there that we'll come back to. But for now, Dr. Hughes, I'd like to move on to you. The US already has the highest maternal mortality rate amongst wealthy countries, and it's growing worse in recent years. With abortion restrictions being enacted across the country, what does the data show about how those restrictions affect maternal and infant mortality?
Thank you, Greg. Yes, I am a maternal fetal medicine physician, as you mentioned, which means I care exclusively for people with high-risk pregnancies, along with my colleagues. These people are at higher risk than the average person for both maternal complications as well as fetal complications. And even before the Dobbs decision in the fall of Roe, there was a lot of data, unfortunately, showing that in states that have more restrictions on gestational age at abortion access, or other restrictions like Dr. Gray was mentioning with long waiting times, in those states, there is an increased risk of maternal mortality. We know that there's a maternal mortality crisis in the United States currently. We are among the worst of developed nations for our maternal mortality rates, and North Carolina, unfortunately, falls right into that level, in that our rates of maternal morbidity and mortality are far higher than one would like to see. There are also a good bit of data showing that there's an increased risk of infant mortality in states with more restrictions on abortion. And in fact, the more restrictions, the worse in many of these studies. We expect this to only get worse with the Dobbs decision. And our concern is that as more states have tighter restrictions, we will unfortunately see higher rates of both maternal and infant morbidity and mortality, particularly here in North Carolina. We know that people who are, as Dr. Swartz was saying, are having an ultrasound that may suggest a fetal anomaly, can't really get definitive testing until after about 16 weeks of pregnancy by amniocentesis, unless they seek care or have a sense that they may be at risk very, very early. And it takes about 2 weeks for the definitive testing to come back if we are to perform an amniocentesis, which is really the way that we diagnose genetic abnormalities. And so the notion that we are able to do an ultrasound at 18 weeks, the patient is then forced to decide essentially immediately whether or not they would like to get genetic testing performed. And then they need to wait for the test results to come back and then be able to grapple with the decision and have a 72-hour waiting period already really makes these decisions excruciatingly difficult for patients, many of whom have a desired pregnancy and have to make the gut-wrenching decision as to whether they want to potentially pursue an abortion, usually to decrease the risk of suffering for a potential neonate.
Absolutely. Thank you, Dr. Hughes, and thank you to all three of our panelists for those opening remarks. Certainly more than we could possibly get through in an hour, but we are going to get to as much of this as we can. We're going to open it up to questions now. Thanks to everyone who submitted questions in advance. You can also post questions via the Q&A window at any time, and I will read them to the panelists. There are now a patchwork of abortion laws across the US, and as Dr. Gray mentioned, individual legislators here in North Carolina have proposed bans at 6 and 13 weeks, as well as an outright ban. Dr. Gray, you mentioned earlier the need for evidence-based care. Can you tell us what does the evidence say about the difficulties that a 13-week ban in particular would create for care?
Right. So I think there is a whole wealth of evidence that suggests any type of ban, while in theory, you know, the goal, or at least the idea, is that these bans are making medical care safer, but the reality is it's making care less safe. And so if we have a ban at 13 weeks or 6 weeks, I mean, most patients don't know they're pregnant at 6 weeks. And, you know, to make a ban at that point, then have a 72-hour waiting period at 6 weeks, that would be essentially an all-out ban. It's very complicated to get care before that point. And then for a ban at 13 weeks, it's an arbitrary point in the pregnancy to choose a ban at 13 weeks. And I think at that stage, patients are still seeking more information about their pregnancy. And you can imagine, let's say a patient has genetic screening at the earliest point in pregnancy that they might be getting just sort of initial counseling. They may not have a diagnostic test that tells them whether something's wrong with their pregnancy or not. And so they're having to rush a decision if they want to seek care in our state. So it's very problematic. And then I think the other really important point is that it takes the guidance and counsel of the physician out of the equation by putting arbitrary bans in place. Bans are not created based on evidence-based medicine, but the care we provide is based on evidence-based medicine. And forcing patients to comply with complicated rules veiled in safety will actually make care less safe. In other states with strict bans, we've seen other ramifications of those bans on other types of reproductive health care. So patients are receiving inadequate care for ectopic pregnancy, which is an emergency situation. Ectopic pregnancy is the #1 cause of maternal mortality in the first trimester. And so we have physicians that are hesitant to treat ectopic pregnancy because of restrictive bans. We see substandard care as it relates to miscarriage care. Sometimes in early pregnancy, there can be complications that may require either a surgical procedure to manage a miscarriage or medications, but we see physicians becoming more hesitant in restrictive states. And part of that is because some of these bans even include ramifications for the physician if they perform care. They have to prove that they're performing the right care by some of these laws, for example, the law in Tennessee. And we're seeing it's impacting physicians and their ability to provide care. It's impacting patients and their ability to receive evidence-based care. And the reality is that bans will not just impact abortion care, but it will impact miscarriage care, early pregnancy care. It will impact care of patients who are reproductive age with other medical conditions. So things like lupus or rheumatoid arthritis, and they need medications that might be teratogenic. Some physicians may be hesitant to give those medications. So there's this chilling effect that happens on the care of patients, and we would see substandard care in a lot of aspects. And I think the other worry that I have is that a 13-week ban is just a stepping stone to further bans with the goal of a complete abortion ban in our state. And I think that would be devastating for the patients that we care for.
Absolutely. Thank you, Dr. Gray. Dr. Swartz, you outlined earlier for us the facts surrounding the law currently in North Carolina. But in 2020, you led research that found many women have little knowledge of abortion laws and also perpetuate myths about the procedure. Can you tell us a little bit more about what you found and how those findings might play out in North Carolina if we end up with tighter abortion restrictions or an outright ban?
Yeah, so what we found in that study was that people were very unfamiliar with the laws on abortion in their state. And the truth is that there's this patchwork of laws that are changing in a lot of places. It's really tough to keep track of what's going on, what the laws and regulations are in your particular state. And that may be a barrier to you seeking care. So it may mean that you think that you can get care when you in fact can't, or it may mean that you think that you can't get care when you in fact can. We know that impedes people in terms of getting to the hospital, getting to the care that they need. And importantly, it's only gotten more complicated, right? Because there are states that are passing new laws, and then those laws will be enjoined by the courts. And so there's this flip-flop back and forth. You know, I think about my colleagues in other states with bans, and, you know, unfortunately, we have moved beyond the theoretical in terms of what the harms of these laws will be. So I've talked directly with colleagues in Tennessee who have not been able to care for people with an ectopic pregnancy. That's a pregnancy that's outside the uterus, that has no chance of resulting in a live birth. And they had to wait for that patient to have a rupture, have a life-threatening bleed before they were able to intervene. That is, you know, beyond the pale of the sort of evidence-based care, even that we provide in abortion. That's just restricting our access to provide gynecologic care. You know, I think it's really important, again, to emphasize what Dr. Gray was saying about the chilling effect on other types of treatment that people may get both in and outside of pregnancy, right? We know from our colleagues in other states that now people are having more difficulty getting access to medications that they need to treat their heart conditions, to treat their lupus, to maybe treat cancer, even if they're not pregnant. And, you know, those sorts of decisions need to be made by people, between the person and their doctor, right? That decision is something that needs to be made in a room between a person and a doctor, not impeded by this legislation. And overall, what the effect is that women simply aren't able to get the same standard of medical care as their male counterparts. That is, you know, totally unjust. It's, I think, outside what the legislators maybe intend with this legislation, but it is a byproduct.
Absolutely. Thank you, Dr. Swartz. Dr. Hughes, you talked earlier about how difficult, you know, genetic testing or the detecting of fetal anomalies is, even with a 20-week ban on abortion. If North Carolina were to end up with a 13 or a 6-week ban, does that mean that essentially the detection of fetal anomalies is taken off the table and is not even possible? How would it look under more restrictive guidelines?
Thanks, Greg. Yes, it means that it would be near impossible to detect anomalies in a timely enough fashion in order to provide patients with the option to pursue termination for severe anomalies. Those, as both Doctors Gray and Swartz mentioned, most patients don't know they're pregnant by the time they're 6 weeks. Most patients are just beginning prenatal care by 12 weeks. Most have not had an ultrasound at that point and would not have a reason necessarily to think that they would need a careful anatomic survey at that point. So unless there was essentially a completely fatal abnormality that could be seen very early, it would mean that we would miss the vast majority, probably over 90% of anomalies, if we were to start evaluating before 13 weeks and think about providing care at that time. It would make it essentially impossible. The other thing that I think is worth pointing out, as Dr. Swartz mentioned, is most unfortunately, it is not rare, nor is it something that is known by the general public. But we do see children and rape victims who are pregnant as a result of both of those things very frequently. This is not a rare event, and those patients very rarely come forward before the end of the first trimester, making the ability to provide care for those patients even more difficult as well.
Thank you, Dr. Hughes. And just to follow up on a point that you just made, I think it's clear, it's important that people understand it. When you talk about 90% of fetal abnormalities not being detectable that early, does that mean then that in an environment in which abortion was either outlawed or forbidden after 6 weeks, that pregnant patients would be forced to carry to term, in many cases, fetuses that were incompatible with life, that had birth defects that were incompatible with life, and they would just have to wait to either miscarry or to deliver a child that had no chance of living? Is that something that would be likely to happen?
That's absolutely right. That's exactly what we're seeing in the states that have these bans. And in fact, unfortunately, what we see sometimes here in North Carolina, when patients are unable to get a full anatomy evaluation prior to that 20 weeks cutoff, which happens also not infrequently due to things like difficulty with accessing care or difficulty with scheduling appointments in advance for their ultrasound. So we unfortunately do see that patients are forced to carry a pregnancy that will not survive all the way to term. And I think most of us can imagine putting ourselves in the shoes of those patients who are walking around in society clearly pregnant and knowing that they will have an infant that will not survive, are unable to deliver legally, and they are subject to friends and family commenting, people in the grocery store talking to them about their pregnancies. And it is frankly a trauma that they endure for the entire time, and leaves them with most unfortunately birth trauma later on that they will need to deal with as well.
Thank you, Dr. Hughes. I think the word Dr. Gray used earlier was chilling, and it feels appropriate in that context. Dr. Gray, I'd like to come back to you. You mentioned in your opening remarks about abortion medication and some of the complications there. There are lawsuits in Texas and here in North Carolina involving the use of a common medication commonly used for abortions. Why are those lawsuits important, and what could they mean for reproductive health care in this state?
So I think a lot of folks who are paying attention to the lawsuit in Texas are really concerned about what this ruling might mean. It could mean that mifepristone could be pulled off the market sometime in this next month. And mifepristone has an outstanding safety record. It's been on the market for over 20 years. And this lawsuit is based on bias. It's not based on science. There have been over 5 million people who've used mifepristone, and so we have a wealth of safety data. And so when you compare mifepristone to other medications, it's incredibly safe. even if you compare it to things that you're able to get over the counter, like Tylenol or ibuprofen, mifepristone is incredibly safe. Yet there are a lot of restrictions around its use because it's an abortion medication. At the time, around the same time that mifepristone applied for approval from the FDA, Viagra also applied for approval from the FDA. And Viagra was approved in 2 years. Mifepristone was approved after 4 years. And we have a ton of safety data since it's been approved. It is probably safer than Viagra if you look at mortality data. And the FDA constantly reassesses mifepristone and its safety, and they have reaffirmed that it is a safe medication. And so it's being targeted. And the goal is to chip away access to reproductive health in every possible way. And this is just one of the other ways that will cut off access to a safe medication, a medication that's used in over half of abortion care currently in the US. About 53% of abortions occur through medication route. This medication is also proven for evidence-based care for miscarriage. So for patients who want to have medication to manage their miscarriage, using mifepristone is safer and it's more effective than what we previously used. So we're very worried about this lawsuit and worried about what it might mean for our patients seeking all types of reproductive health care. We will have alternatives to using mifepristone, but they're a little less effective, which means that patients may need more follow-up care, may need more procedures if their medication is not effective. And so we're paying very close attention to that right now.
Absolutely, thank you. Dr. Swartz, you mentioned ectopic pregnancies as one example of a case in which the life of a pregnant mother is at risk. For abortion bans and restrictions that make exceptions to protect the life or the health of the mother, how much information do we have on whether her doctor's word would be sufficient evidence? And if not, are there any models kind of showing how that call would get made?
Yeah, I mean, unfortunately, the nature of these abortion bans is that they are not written by physicians, right? And so any ban, any set of restrictions does not apply to 100% of the cases for which it needs to be applied. And so what it does is it puts an extra layer of difficulty in providing care. And means that people aren't providing the essential care that they need to do. So when we talk to colleagues from other states, sometimes they're talking with a committee before they're able to intervene in a patient's health. Sometimes they are having to seek an ethics consult. More often, I think they're referring the patient to some other center to sort of kick the can down the road. It results in an untenable situation where we know that care just gets more dangerous. One of the situations that I think about is that can commonly occur in pregnancy, unfortunately, is when people break their water prior to the time that the fetus is viable. Now, this is a condition where the evidence-based care, the standard of care, is to offer compassionate counseling, but to offer abortion, to offer termination of pregnancy. This is an inevitable abortion. And here's why. The fetus no longer has fluid around it. So the lungs can't develop. So it has very poor fetal outcomes. And importantly, the mother is at really significant risk of developing a life-threatening infection or life-threatening bleeding. Well, in Texas, where they had one of the earliest implemented abortion bans, researchers have shown that, no surprise, when people don't have access to that care, they have incredibly high rates. So 60% of them suffered some major morbidity or even mortality as a result of having to wait. So what happens in those states? Well, people break their water, they get the diagnosis, whereas previously they would have, had the counseling and said, listen, we can do an induction, we can do a surgical abortion, or we can provide, we can wait if you want to. Now they say, well, we just have to wait. Come back when you have a fever. So my colleagues are discharging people into the world to wait for them to get sick. In a setting where we know what the diagnosis is, where we can provide, evidence-based and effective treatment, what we want to do is keep our patients as safe as possible, particularly when that is in line with their philosophy, their decisions, and their feelings about how they want to approach the pregnancy. We don't want to wait for something to get worse. And when it gets worse, it's just harder to treat. Those are some of the scariest cases that we see. And unfortunately, this is just really common. And even when that care might be exempted, for example, so even when they say, well, you are able to treat this care, it just makes it more complicated because people very justifiably, physicians fear, well, if I do this treatment, am I going to get penalized by the state? Is someone going to step in and say, well, this wasn't life-threatening enough? We shouldn't have to make a decision about whether something is life-threatening enough to act to save a patient's life.
Absolutely. Thank you, Dr. Swartz. Dr. Hughes, what would, if we were to end up with a 13-week ban, 6-week ban, or an outright ban in North Carolina, what could that mean for the availability of prenatal care in general in this state, and why does that matter?
Thanks, Greg. Yes, we already have several maternity care deserts here in the state of North Carolina. People have difficulty accessing prenatal care to begin with. And we know that people who are at highest risk for long-term complications, medical complications, may live in poverty, have an even higher risk of have an even more difficult time accessing prenatal care. And so a ban such as what you described, like a 13-week ban, would move the imperative to try and encourage people to access prenatal care much earlier than they do routinely now, which would potentially overwhelm our already strained prenatal care providers here in the state. It would be quite difficult for people to actually be able to access early prenatal care as regularly as they would need to, particularly those with underlying medical conditions. In my mind, there is no question that if we were to have a ban that is worse than the one that we currently have in the state of North Carolina, we will see increased maternal mortality. It is not a question, it is a fact, as has been demonstrated in multiple other states. And so the concern that we have is that if that were to be the case, how will the high-risk obstetricians in this state try to care for all of those patients who are now forced to continue pregnancies, recognizing that they have this high risk of mortality? And frankly, we don't have an answer at this point.
Absolutely. Thank you, Dr. Hughes. Dr. Gray, I'd like to come back to you for kind of a basic question here, because I think it can help clear up a misconception. Can you talk a little bit about the procedure itself? Is abortion done under clinical conditions a safe procedure?
Absolutely, Greg. It is a safe procedure. There is a whole wealth of safety data around the provision of first trimester and second trimester abortion care. And it's a well-studied procedure with excellent safety data. And we know that carrying a pregnancy to term is much more risky for a woman in just her lifetime risk. And so I think that comparison is an important one to make. I think another point I'd like to make, just related to what Dr. Hughes was discussing, is that, even before the fall of Roe, the patients in our state already faced incredible inequities in care. And if we have further abortion bans, the patients who will be able to seek care, there are disparities there. So patients who live in rural areas, who may not be able to afford childcare, to be able to take off a day or two to go to another state to get care. You can imagine the barriers that people face. And so if they can't access care in our own state, going to another state is going to be incredibly difficult. And it's just sad to me that we would have doctors here who have the capabilities to provide the care that patients need, and we have to send them elsewhere for care. It's heartbreaking for those patients. And so you will have disparities in who can get care, who can travel for care, and it will just perpetuate the inequities in maternal health care, maternal mortality in our state.
Absolutely.
Jump on something Dr. Gray said, that when you think about who do you trust and who do you go to help you make decisions about healthcare, I think few of us would say that we're going to go to a legislator to help understand our healthcare better. The National Academies of Sciences, Medicine, and Engineering released a comprehensive report on the safety and quality of abortion care, in which they conclude that legal abortion is really safe and high quality in the United States, and that restrictions such as the ones being considered in North Carolina only create barriers to care and make care difficult to access. They do to make care safer. Practice evidence-based and safe healthcare in this situation. And what the legislature is talking about imposing are ways to take away our ability to provide that care or make providing that care more difficult. And there's no way that that's going to benefit patients.
Absolutely. Thank you, Dr. Swartz. Dr. Hughes, I'd like to come back to you on the issue of maternal morbidity and mortality, because, of course, an elephant in the room here is that even if abortion is outlawed, history has shown us that pregnant patients will still find access to abortion somewhere. What happens if the rate of non-clinical abortions increase? Because obviously those women are going to end up needing additional healthcare, often in those cases. But what does that look like in a state where, if in a North Carolina in which abortion is outlawed, but people are still seeking abortions somewhere?
That's right. Having started my training in the late 1990s, I had mentors and educators who knew the time prior to Roe, when the non-clinical abortions were done regularly, and people often died of infections from those non-clinical abortions. We will undoubtedly see an increased risk of infection because, as is again well known in the medical community, you can not stop abortion. You can only stop legal and safe abortion. People will seek abortion in non-clinical settings or in other states. And again, just adding on to what Dr. Gray was saying, we know that Black pregnant patients in the United States have more than 3 times an increased risk of maternal morbidity and, most unfortunately, of maternal mortality than white patients. And we would expect to see that disparity exacerbating in the setting of a ban, which is frankly exactly what we are all fighting against. We in the high-risk pregnancy world and in the abortion care world, we know that the provision of abortion keeps people safer. And we have developed many interventions to try and decrease the impact of racism, structural racism, the ability to access care, to improve this shocking disparity that we have in the United States and here in North Carolina. And unfortunately, putting in a ban, any ban, will only exacerbate that disparity, and is something that is exactly what we are striving to reverse, unfortunately.
Thank you, Dr. Hughes. Dr. Gray, I'd like to come back to you. We've kind of briefly touched on this, but I'd like to talk a little bit more about it. Obviously, there are lots of pregnancies that end in miscarriage, but in what ways does miscarriage management overlap with abortion care? And what do laws restricting abortion, what kind of effect do they have on your ability to manage miscarriages?
So the procedure that a patient would undergo if she had a miscarriage, or the medications we would use to treat a miscarriage, are exactly the same as those that we provide in abortion care. And so there's no difference in the technical aspects of the procedure or the medications. They're exactly the same. And so we worry, because there is this stigma and legislation around abortion care, that it will kind of spread into impacting miscarriage care. And I think sometimes in early pregnancy, when you're trying to determine if a patient has a miscarriage or a normal pregnancy, they can have complications before you have a diagnosis to say, okay, this is a normal developing pregnancy, or this is a miscarriage. And so we worry about limitations and bans impacting our ability to intervene and help a patient who is likely having a miscarriage, but maybe doesn't meet all the criteria to say she's having a miscarriage, but needs care. And so there have been some examples, some patients who have come out on social media talking about their experiences with, bleeding in early pregnancy and their doctors not willing to treat them because there may have still been evidence of cardiac activity, even though they're bleeding to the point where they're needing blood or needing hospitalization. And so I worry about patients that fall into that category. And I think the other example that Dr. Swartz brought up is, when someone breaks their water early in pregnancy, that's an incredibly risky pregnancy, both for maternal health and for outcomes for the infant. And so I think those are situations where historically we would have offered evidence-based management or care for those patients, which would be to intervene and treat those patients for their inevitable miscarriage. But with these laws in place in some states like Texas, there is a lot of hesitancy around intervening and caring for those patients.
Absolutely. Thank you. Dr. Swartz, what do we know about how abortion bans affect embryos created via in vitro fertilization? Obviously, there are a whole bunch of different issues there.
Yeah, so depending on the timing of the abortion ban and when they put it into place, it often misrepresents what we understand about pregnancy. And so we define pregnancy as implantation, which happens several days after the egg is fertilized by the sperm. And so there are several states that have banned abortion as soon as fertilization, which and then through that may impact in vitro fertilization care, where that embryo would be created outside the uterus. And so then, I think our reproductive endocrinology colleagues are grappling in those states with, well, what do we do? Can we create more embryos than we need to in order to, achieve a pregnancy? Oftentimes it's putting someone through hormonal treatments as well as procedures to get eggs, and then to create those embryos. And so it makes sense to create more embryos than you need to put into the uterus at one individual time. That's just part of the care. You need those extra embryos because, IVF is not 100% in terms of its success rate. And so what it's meaning is that perhaps you don't have control over whether you have enough embryos created. Perhaps you have to have additional procedures performed. Perhaps you aren't, there's some question about what you do with those embryos that are in a freezer waiting in case you need to use them. I think it really, raises some complicated issues, and again, speaks to sort of the collateral damage that these abortion bans have done, because it's really taking, a shotgun to a problem, which is, at its base ideological. The bottom line is that the science has not changed since the Dobbs ruling. The medicine has not changed. All that's changed is this ideological impetus to pass further bans. And so, we are doing our best to provide the best care for the patients that we care for, to keep them safe, to allow people to make decisions about their own bodies. And what these bans do is they take away our ability to do that and take away our ability to provide the best care for our patients.
Thank you, Dr. Swartz. Dr. Hughes, I'll move on to you, and I'd like to get everybody's perspective on this. Obviously, we've seen quite restrictive bans enacted in states close to North Carolina, and there is now the threat of potentially legislation here. What kind of concerns are you hearing from your patients? Have you seen impacts from the laws enacted in states near to North Carolina? Has it placed a burden on kind of healthcare resources here? What kind of things are you seeing on the ground, so to speak?
Yes, unfortunately, I have many colleagues who are in states that have severe abortion restrictions, and they are seeing both ongoing risks to moms, as well as what both Doctors Gray and Swartz were mentioning earlier, with even difficulty providing GYN care. There are times when folks that I know in other states have had patients who were actively hemorrhaging in the middle of the night, and were unable to provide care until they were able to escalate to a board to be able to get permission to prevent someone from actively dying at 2 o'clock in the morning. I think it's been said already, but we've moved beyond the theoretical. We are seeing that these bans are impacting patients, making them less safe. It is leading to physicians feeling unable to move forward and care for patients the way that they would want to, for fear of being prosecuted for providing appropriate patient care. And it is also leading to, frankly, physicians leaving such states in droves because they don't want to risk having to go to jail for taking care of a patient. Something that we all learned in medical school is that we provide care for our patients when they need it, and the ability to be able to do that being taken away and put in the hands of legislators as well as in the hands of non-physicians on the ground has really impacted the ability for folks to provide care adequately. I think we've talked about the risks of having somebody's water broken. We see hemorrhage. I take care of patients every day who have heart failure, cancer, transplants, kidney failure. We see the onset of pregnancy-induced high blood pressure that is life-threatening. And we see these things literally every day. And those are the things that we need to be able to provide care for without being fearful about being prosecuted for taking care of patients.
Thank you, Dr. Hughes. Dr. Gray, I'm interested in your perspective, from kind of an on-the-ground level too, but I'd also like, if you can, to speak to what this could mean for access to other obstetrics care in the future. Is this going to lead medical students to stray away from this area because of the fear of prosecution? And what could that mean for access to patients, access to care?
So I think we're seeing patients cross state lines to receive care if they live in a state with restrictive bans. I think one of the things that Dr. Hughes talked about before is that, patients, when they receive a devastating prenatal diagnosis that something has gone horribly wrong with their pregnancy, they don't want their child to suffer. I'm a mother of 2 kids, and as a mother, I don't want to see my children suffer ever. And if I received a diagnosis that was devastating to a pregnancy, that's a decision that I would make thoughtfully with, my family, my physicians. But at the end of the day, I would not want to see my child suffer. And I think sometimes it's lost in the mix that sometimes patients see abortion as an act of compassion and an act of motherhood. And we can't forget that. And so patients will cross state lines. They'll travel for care if it's necessary. And so we're seeing that. And I think as a residency director, the other thing that I see is that people making the decisions about where to live and train are impacted by state laws. So I have already seen the impacts of potential bans on, residents applying to certain states or not applying to other states because they want to get the training to be excellent OBGYNs. And abortion training is part of comprehensive abortion or comprehensive OBGYN training. And so to be in a state where you can't receive that care, you're inadequately trained, period. And so medical students are very thoughtful about making those choices. I think, I don't know what the impact kind of, long-term for our field will be, but I do worry that it will impact who decides to become an OBGYN. I mean, people just want to do their jobs. I just want to do my job and not have someone interfere with the evidence-based medicine that I can practice on a day-to-day basis. And so it's hard to enter a field where you might be told, well, if you live in this zip code, you can't provide the care that's necessary to people.
Thank you, Dr. Gray. Dr. Swartz, I'd love your perspective too, and in particular, how often you feel, in the event of a more restrictive ban in the state, how often you feel like you'll be faced with a situation where you're not sure, like, how much care you can provide because the law, as you say, isn't based in evidence, and is going to create confusing situations for doctors and their patients.
Yeah, I mean, I think that that does create a real new challenge for physicians on the ground who are, busy providing care in a bunch of circumstances, and now would have to take extra time potentially to review a hospital policy, maybe talk to a board, as Dr. Hughes suggested. Those just aren't fair burdens to put on physicians. To Dr. Gray's point and Dr. Hughes's point, I mean, who wants to practice in that environment? So whether you don't want to do the specialty, maybe you don't want to be in a state that's restrictive, I think we are going to see shifts in the workforce. I also just want to speak to what it's like to care for a patient who is seeking an abortion from out of state. The only circumstance I can liken it to is, which is, obviously much more trivial, but I think how hard it would be for me to get a haircut out of state, right? To select the right barber in another city, to figure out how I was going to get there, to figure out how long I needed to stay, whether this was the right barber for me, whether the shop was going to be in a good part of town. These people are doing something that is more consequential in that it's much more intimate. It's an actual medical procedure, right? And so they have to choose these clinics from out of state. They have to arrange, on top of the abortion, all these other logistics in terms of travel, in terms of caring for the kids that they have at home, in terms of getting time off work, perhaps disclosing to their employer that they're seeking medical care, and then travel out of state, stay multiple days. So it really increases a ton of complication and difficulty for patients to get this essential health care. And oftentimes they're even traveling to get medication abortion, right? So a simple pill that we can get in the office, they're having to go across state lines or multiple state lines in order to get that care, and that's crazy. I also, if I could, do my study that people commonly believe about abortion. And I think it's really important to dispel some of those myths, as well as some myths that I've heard commonly repeated now. In our study, people commonly believe that abortion causes depression. The truth is that people have positive psychological outcomes, with being able to access the abortion that they want. We know that their long-term psychological outcomes are improved as a result of being able to get the abortion that they want, as well as their economic circumstances, bonding with children. So there are positive things that are associated with abortion. People commonly believe that abortion is less safe than childbirth. The truth, very well established, is that abortion is safer than carrying a pregnancy to term. The other myths that I've heard that are problematic in our setting are about pain. So, abortion in the second trimester, people commonly concerned. My patients ask me, because they care about their bodies, because they care about the idea that their fetus might experience pain. They ask, is there pain? The pain response does not develop neurologically until 24 to 28 weeks. So it's well after we're providing abortion in this state. It's a complex neurological process that's just not happening. The other common myth I've heard propagated is that abortion is occurring late in pregnancy. Abortions are not occurring up to the moment of birth. That is simply not occurring in our state or anywhere. When people have a baby at term, even a baby that's sick or a baby that they aren't interested in parenting, we deliver that baby and we provide medical care for that baby. So abortions are not happening at the moment of birth. And it's very upsetting to hear that myth repeated, including in North Carolina.
Thank you very much, Dr. Swartz. I appreciate you taking, the opportunity to correct some very, very common misconceptions. We're going to be wrapping up here very shortly, but I wanted to give each of you one more opportunity to speak. And Dr. Hughes, I'd like you to maybe kind of somewhat reiterate a point you made earlier, and just re-emphasize for people how often you see pregnant patients, in many cases pregnant patients and non-pregnant patients, whose medical care would be affected by an abortion restriction, whether it's a pregnant patient who wants to carry a baby to term or just a woman who needs care that would somehow be affected. How often does that happen?
Yeah, thank you, Greg, for putting it in those terms. And frankly, it's all day, every day. I care exclusively for high-risk pregnancies. And there are dozens of high-risk pregnancy physicians in the state of North Carolina. And that is exactly what we do all day, every day. We care for patients. We diagnose their anomalies. We diagnose their genetic conditions that may exist in a fetus. We care for them in early pregnancy and throughout pregnancy if they desire to, if they've got heart failure, if they've got severe diabetes, if they've got cancer. And I think ultimately the important thing that is available to them is the choice. We know that those patients and fetuses are at higher risk for not doing well with pregnancy. We know that if they continue pregnancy, they are at higher risk for maternal morbidity and mortality, and for infant morbidity and mortality when they have fetal anomalies. What they have and what we would like for them to have as their physicians is the choice to decide whether or not they are willing to take that risk, or if they, for their own personal reasons, whether that be their ability to care for a child or themselves, or their own personal worry about being there for their other children, that they will have the choice to be able to decide whether or not abortion care is right for them.
Absolutely. Thank you, Dr. Hughes. And Dr. Gray, before we wrap up, the word chilling has come up more than once today. And if you like, I'd like to give you the opportunity to briefly state why further restrictions on abortions are so chilling.
So I think the reality is that, we all know and love someone who's had an abortion in their life. People need this care for a variety of reasons. And 1 in 4 women, by the time they reach menopause, will have had an abortion. And so that's very, very common care that people in our state are seeking. For me and my own family, it was my grandmother who faced a diagnosis of cancer and pregnancy at the same time and had an abortion that saved her life. And I think until you personally are faced with the decisions that our patients have to face on a daily basis, it's impossible to understand how thoughtfully they approach these life and health decisions. Most of them are seeking counsel from their family, from their faith leaders, and from their physicians. And we just hope to be able to provide people with the care that's necessary, the care that's life-saving, and the care that's so important in our state.
Thank you, Dr. Gray. Dr. Swartz, you are a father, and like Dr. Gray and Dr. Hughes, you provide a range of care to many, many patients. What would further restrictions on abortion in this state mean to you on a personal level?
Yeah, I mean, I want my kids to grow up in a place that they have control over their healthcare decisions and the decisions that affect their bodies. And so it is scary to think about growing up in a state where that sort of autonomy is taken away from them. Look, the science is clear on that. On this, I hate to sound like a broken record, but it's, this is the reason that the American Medical Association, the American College of Obstetricians and Gynecologists, the World Health Organization, the North Carolina Medical Society, the North Carolina OBGYN Society, all affirm that abortion is an essential component of healthcare because people need this care. As Dr. Gray said, people need this care commonly, and any abortion ban that is put into place will subtract from our ability to safely care for patients. So it's a scary prospect that we're going forward and sort of talking about the imposition of those restrictions for our patients.
Absolutely. Thank you, Dr. Swartz. I think we will call it there. Thank you, everyone, for joining us. Thank you to our panelists, Dr. Beverly Gray, Dr. Jonas Swartz, and Dr. Brenna Hughes, for sharing your expertise and individual opinions. We will certainly be addressing this issue again in the future. In the meantime, we'll be back on Tuesday to discuss the passing of 1 year since Russia invaded Ukraine. If you would like to be notified about that or any of our other briefings on whatever this perplexing decade continues to throw at us, please email dukenews@duke.edu. In the meantime, please stay safe and stay sane. Thank you very much for your time.